we discuss today the current treatment of hepatitis C virus. As we know, hepatitis C virus infects 170 million people worldwide. 350,000 die every year from hepatitis C virus. Hepatitis C is a progressive disease, lead to liver fibrosis, cirrhosis, and hepatocellular carcinoma. The hepatocellular carcinoma didn't develop except when there is cirrhosis in patients with hepatitis C virus, but in patients with hepatitis B virus, hepatocellular carcinoma develop with or without cirrhosis. There is extra-hepatic manifestations of diseases from hepatitis C virus. As we know, hepatitis C virus is a progressive disease. It leads to hepatocellular chronic liver disease, liver cirrhosis, hepatocellular carcinoma. The hepatitis C virus, there is extra-hepatic manifestations. It may affect the brain, may lead to depression, thyroid dysfunction, lymphoma, kidney diseases like glomerulonephritis, sexual dysfunction, skin like lichen planus, and may lead to systemic vasculitis. This is extra-hepatic manifestations of hepatitis C virus. Before, we cannot treat the viral C hepatitis by interferon because it is contraindicated when these diseases is present, like thyroid, like any autoimmune associated hepatitis C virus. But today, we can treat the hepatitis C virus even in the presence of these extrahepatic manifestations. The hepatitis C virus is a curable disease. Hepatitis C virus, there is an oral antidepressant with cure rate over 90%. Every step of hepatitis C life cycle can be the target of a specific inhibitory approach. As we know, the hepatitis C virus, there is parts of it with its structurable protein and non-structurable protein. Therefore, this is a part of virus. There is protease, there is protease inhibitors, polymerase, there is polymerase inhibitors. Therefore, this is the parts of the virus itself. Therefore, there is drugs. Every group can attack a part of the virus. Therefore, till now, about 3 parts of the virus can be attacked by these drugs. Therefore, this is the drugs available now. The group, the first group, which is the backpoint, which affect NC5B, which is the first drug, sofosbuvir, uh, which is known Sovaldi, and there is different names for sofosbuvir now, and others, which is attack NS3, NS4A, like simiprevir and other protease inhibitors. This is the drugs going every day with a new drug attack a different part of the virus. We say now some of these drugs. NS4B, this is approved in 2013 and 2014, which is sofosbuvir, and it is active against all genotype and has a higher barrier to resistance. Second, from 1914 to 1915, from a group NS3-4A as simiprevir, it active against genotype 1-4, not genotype 3. Crasoprovir pan genotype, but not against viral genotype 3. Therefore, the NS5A as daclatasphere pan genotype, lidipasvir against genotype 1 and 4 as a single pill containing fixed dose of sofosbuvir and lidipasvir, which is known as Harvoni. Others, ompicivir pan genotype, available as component of fixed dose combination with ritonavir, previr. They have low barrier to resistance. Elpasvir in combination with grazoprevir in one single pill will be in 1916. It is pan genotype. What is the problem? The problem, these drugs, when used as monotherapy, it is very effective, but there is a relapse after 7 to 10 days, maximum 3 to 7 months post-dosing. Therefore, these drugs cannot be used by itself. There is no monotherapy. Therefore, the resistance has been reported with these new molecules when used as monotherapy. What is the solution for this problem? The solution is the combination therapy. We use one drug together with other, with or without ribavirin. Therefore, there is resistance at that time. There is no breakthrough. There is no relapse. Therefore, the combination of different types of these drugs with or without ribavirin make it very effective to reach more than 90% success. Therefore, sofosbuvir has a high barrier to resistance. It can be used as backbone of therapy. In every drug, we add sofosbuvir. Therefore, because it is a backbone of therapy, in combination with other drugs with low barrier to resistance, with or without ribavirin. Therefore, sofosbuvir is resistant and the resistance, and it is the backbone. We add to other drugs, it is very strong with this sofosbuvir. When no backbone, because sofosbuvir sometimes not suitable for some patients. Therefore, when no backbone, that is to say, no sofosbuvir, which is high barrier of resistance. Therefore, we use the combination of three drugs of low barrier to resistance. These three drugs together achieved a high barrier to resistance with or without ribavirin. Therefore, either we use the sofosbuvir, which is a high barrier to resistance, together with another drug of low barrier of resistance. If sofosbuvir is not suitable, therefore we use three drugs of low barrier of resistance together have a high barrier to resistance with or without ribavirin. Therefore, combination of high barrier to resistance, as we said before, sofosbuvir as a backbone with low barrier of resistance with or without ribavirin. Therefore, as we see now, sofosbuvir together with ribavirin, it is suitable for genotype 2 and also genotype 3. Also, sofosbuvir with another drug, which is semiprevir in genotype 1 and 4. Again, sofosbuvir with lidispavir in one single pill in genotype 1 and 4, which is known as Harvoni. Again, sofosbuvir with daclatasphere for all genotypes. This is sofosbuvir, a high barrier of resistance with other drug with a low barrier of resistance, together strong treatment with or without ribavirin. But when there is no backbone, there is no sofosbuvir, what we can do? It is a combination of 2 or 3 drugs of low barrier to resistance without sofosbuvir, which is the backbone, which is a high barrier of resistance. These 2 or 3 drugs achieve a high barrier to resistance. For example, ritonavir, boosted paritaprevir, and ompidasvir in one single pill can be used in genotype 4 or in combination with dazabuvir in genotype 1. Therefore, if we look, we find that genotype 4, everything is suitable for it. Interferon was not suitable. It is only for 60% of cases. But this new therapy is suitable for genotype 4, which is the Egyptian genotype. And I said before, when we know the genotype 4, I said it is pharaonic genotype. It is genotype 4, which is all the Egyptian people nearly have genotype 4. As we see here, the combination of this treatment suitable for genotype 4, all for genotype 4. Therefore, as genotype 4, suitability Bouvier, Lidis Bouvier, Sufus Bouvier, Ribavirin, Simibrivir, Subobrivir, and so on. Therefore, we conclude the antiviral strategies. A backbone with high barrier to resistance and combination with low barrier to resistance with or without ribavirin, or combination with 2 or 3 drugs with low barrier to resistance without backbone with or without ribavirin, altogether achieve a high barrier to resistance. Therefore, before we classify our patients for the treatment, we prefer to treat not the early cases, but the late cases. But now, after the new drugs, which they are marvelous for the management, more than 90% success. The treatment for all patients, compensated or decompensated chronic liver disease, who are willing to be treated and who have no contraindication to treatment. Therefore, what is the goal of therapy? The goal of treatment is to cure infection. Why? To prevent complications of hepatitis C related liver diseases, which is necro-inflammation, fibrosis, cirrhosis, hepatocellular and death. Also, to treat the extra-hepatic diseases related to hepatitis C virus. The endpoint of therapy is undetectable HCV RNA. After the end of therapy, we say sustained virological response when 12 weeks after the end of the treatment and there is no recurrence and the HCV RNA is still negative, or 24 weeks after the end of the treatment and it is there is no recurrence of the virus. Therefore, we say SVR with 12 or SVR 24. What is about the relapse after 24 or the response to treatment? Late relapse is extremely rare with the direct-acting antiviral therapy. Therefore, if there is the virus return again after 1 year, it is not a relapse. It is a new infection, new from other patients with hepatitis C virus. SVR corresponds to a definite cure from hepatitis C infection. Before we leave this point, therefore, the patient become cured when the HCV RNA negative, but still anti-HCV positive and never disappear. Therefore, the patient usually asks why it is present and I am treated. You are treated from the replication of the virus, but this antibody persists for life. Therefore, the management of different cases. The management of hepatitis C virus with hepatitis immunodeficient virus co-infection. They have sustained virological response as hepatitis C virus monoinfection. We use soposbuvir and lidspivir or soposbuvir and daclatasphere. Please take care. To avoid toxicity, avoid tenofovir with soposbuvir, lidspivir, or close monitoring for renal function if co-administration is required. We are confronted with patients with decompensated cirrhosis. All oral antiviral therapy for child B and C, but usually I don't like to treat patients with hepatitis C virus when cirrhosis child C. Therefore, when the patients with decompensated cirrhosis for child B, as I prefer, and not child C, as I don't like to treat them, sofosbuvir, lidspivir, sofosbuvir, ribavirin, sofosbuvir, daclatasphere, semiprevir, sofosbuvir for child B, but not encouraged by guideline. Sustained virological response in decompensated cirrhosis are lower than that with compensated cirrhosis. Decompensating or portal hypertension associated with reduced rate of sustained virological response. Antiviral therapy to improve symptoms and survival. End-stage renal disease, it is special problem. Sofosbuvir is renal clearance and metabolite increased 5.5 folds in severe kidney diseases and 13.8 to 21.7 fold in dialysis. Therefore, sofosbuvir is not approved with creatinine clearance. Sofosbuvir, the back point, which have a high against resistance. What we can use? We can use combination of drugs with low resistance together become highly effective. Ompitasphere, baritaprevir, ritonavir, and dasapuvir together with or without ribavirin. All patients achieved sustained virological response at 12 weeks, SVR 12. Combination of carazoprovir and elpasvir appears promising. End-stage renal disease patients have the fewest treatment options. As we see here, this is the list of treatment. Sofosbuvir not indicated when renal clearance, creatinine clearance below 30. Lidspivir, it is hepatic, not indicated. Semiprevir, not if creatinine clearance below 15. Baritaprevir, yes. Ompitasphere, yes. Dasapuvir, yes, we can use. Ribavirin, yes. Therefore, we can use these drugs in patients with end-stage renal disease. Therefore, it is very limited. Very limited. Therefore, baritaprevir, tasfir, dasapuvir, ribavirin. All these can use, but not sofosbuvir, not sofosbuvir. And therefore, today's the treatment for the end-stage renal disease now available, which is known as curable. It is taken 2 tablets after lunch, and we add ribavirin 400 milligram, 1 tablet after lunch. This is the treatment of choice for patients with end-stage liver disease. What is about the transplant recipient? Sofosbuvir and ribavirin for 24 weeks, sustained virological response 70%. Sofosbuvir, semiprevir with or without ribavirin for 12 to 24 weeks, sustained virological response 90. Tasfir, pari-taprevir, ritonavir, and dasapuvir with or without ribavirin, sustained virological response 12 SVR 12, 97%. Lidipasvir, sofosbuvir with riba 12 week SVR 96. Severe cholestatic hepatitis as aggressive of recurrent hepatitis C virus, typically seen in the first 6 months after liver transplantation, can be safely and successfully treated with sofosbuvir. What is about the complexity of this treatment in transplant patient? Sofosbuvir levels are increased on cyclosporin. Tacrolimus do not affect semiprevir level. Therefore, it is better to use tacrolimus. Mycophenolate mofetil levels are increased on sofosbuvir, lidipasvir, and monitoring for levels. Pari-taprevir, ritonavir increases the levels of tacrolimus, cyclosporin, sirolimus, and everolimus. Dose of these drugs need to be reduced in patients on omeprazole, pari-taprevir, ritonavir, and dasapuvir. Therefore, the optimum timing of therapy in transplant recipient has not been established, but it is at least 6 months post-liver transplantation when the clinical status was stable. Ribavirin-free therapy would be desirable to further improve tolerability of therapy. In conclusion, liver transplant recipients have sustained virological response rate similar to those without transplant. Treatment more frequently requiring ribavirin or longer duration of therapy, but ribavirin-free therapy is desirable. It is better to avoid the use of ribavirin. Drug-drug interaction with some direct antiviral drugs, optimal timing of treatment is still not established. Therefore, we take home this message. Hepatitis C virus infection is curable disease. Hepatitis C virus oral antiviral therapy with cure rates over 90%. Treatment for all patients compensated or decompensated chronic liver disease. HCV is a progressive disease treatment prevent HCV liver diseases, also HCV related extra-hepatic diseases. Therefore, I can say thank you and goodbye to see again about the success of antiviral therapy, the success of treatment of hepatitis C virus, and what we can do when the virus has gone. See you later. Thank you.